Just proximal to this, the inferior epigastric artery, useful as a landmark during hernia repairs, and the deep circumflex iliac artery arise from the external iliac artery, providing crucial blood supply and collateral potential in the pelvis and lower abdominal wall. The intermediate compartment of the sheath contains the femoral vein, which lies directly medial to the artery and is a frequent site for venous access and deep vein thrombosis formation. The femoral vein accepts several tributaries within the triangle, most significantly the deep femoral, or profunda femoris, vein and the great saphenous vein, the latter being a long superficial vein frequently harvested for coronary artery bypass graft procedures. The most medial and important clinical compartment of the sheath is the femoral canal, which is the smallest and contains extraperitoneal fat, loose connective tissue, small lymphatic vessels, and a specific deep inguinal lymph node referred to as the node of Cloquet or the lacunar node, which is clinically useful as its enlargement may signal potential metastases from lower limb malignancies or drainage from pelvic structures. The canal itself, because it remains essentially a relative empty space, serves a physiological function by providing a space into which the adjacent femoral vein can expand when venous return from the lower limb is acutely increased, such as during periods of heavy physical activity or increased abdominal pressure. The proximal opening of this canal, located superiorly, is the femoral ring, which is a key potential point of herniation. The borders of this rigid femoral ring must be clearly understood for surgical and clinical diagnosis. It is bordered anteriorly by the inguinal ligament, posteriorly by the pectineal, or Cooper's ligament, resting on the pectineal line of the pubis, medially by the rigid curved edge of the lacunar ligament, and laterally by the fibrous septum separating it from the femoral vein. Because these borders, particularly the lacunar and inguinal ligaments, are relatively unyielding, they significantly constrict any structure entering the ring, making the femoral canal a common and dangerous site for femoral hernias. Femoral hernias, which are more frequent in elderly women due to a wider pelvis, present as a protrusion of an abdominal structure, most commonly a loop of small intestine, through the ring and into the canal. This mass will appear inferolateral to the pubic tubercle, distinguishing it from an inguinal hernia, which is superomedial to the pubic tubercle. A crucial consequence of the rigid, narrow borders of the femoral ring is that a femoral hernia is highly susceptible to incarceration, where the trapped contents cannot be reduced, and even more dangerously, strangulation, which involves compression that occludes the vascular supply leading to bowel ischemia and potential necrosis. This condition presents as a medical emergency requiring rapid surgical intervention. The femoral triangle itself also serves as a vital clinical zone for several procedures. The femoral pulse is readily palpable just inferior to the mid-inguinal point, located between the anterior superior iliac spine and pubic symphysis, marking the point to access the femoral artery. The relatively medial position of the vein makes it accessible for venipuncture or central line insertion, using a landmark approach of palpating the adjacent arterial pulse.